Our next guest is Dr. Charles Freed. He's the Chief Medical Officer of Behavioral Health Services for United Healthcare. And he's going to be talking about treating opioid use disorder using FDA approved medications. So, we're going to get into some MAT, medication assisted treatment here. And this is a big deal with this crisis. This is one of, I think, the most important issues that we're going to talk about today. Are you there, Dr. Freed?
Can you hear me now?
I can hear you now.
All right, I'm here. I'm ready to rock and roll.
All right, well, I will pass it on to you then.
Oops. Can you see it? The presentation?
I certainly can.
All right. So I think we're ready to go. I talked about topics. I think that's where we may have lost one another. Then I jumped into this slide that shows overdose trends, and it actually demonstrates or reflects there have been three trends. The first wave, they call them, was the rise in prescription opioid overdose deaths. And one thing I want to make you aware of is that we have been stating that we have an opioid epidemic for the past, I don't know, 5 years, 6 years. But the actual rise in opioid overdose secondary to prescribed opiates started way back in 2000. So we, in retrospect especially, we probably should have been a little more attuned to that growing trend. The second wave, when you squeeze the balloon, it pops out somewhere else. And the squeezing the balloon in this case was to begin to put restrictions on opioid prescribing, which was out of the box in the first place. And once opioid prescriptions became harder to come by and harder for people to sell on the streets to make available to the general population who wanted it, they started to move to other substances. And that was specifically heroin. And so you see that yellow line reflecting the rise in overdose deaths related to heroin. And what I think surprised or shocked a lot of people is wave 3. And that is looking at the impact primarily of fentanyl. Fentanyl is a semi-synthetic opiate. It has a legitimate, valid use for individuals, usually those with cancer who need high dose, continuous high doses of opioids to address their pain. And it comes in the form of a patch that a person can put on, and it delivers the product over time. Well, the people started abusing the patch, but then learned how to make it. So most of the fentanyl that we are seeing on the street in this day and era is manufactured. And a significant amount of that occurs in Mexico. The next slide we will go to, I apologize, it's a little bit busy, but it's looking at, again, fentanyl. Look at the bottles on the left, lower left. Heroin, fentanyl, carfentanil. What's carfentanil, some of you ask? Carfentanil is supercharged fentanyl, which is already supercharged itself. So what you see at the bottom of those vials are the quantity that would result in overdose of an individual. And you see that fentanyl compared to heroin, there's much less fentanyl that's required to um, lead to someone undergoing respiratory depression. Then when you look to the carfentanil, you see it's just a small pinpoint amount of that substance. What's carfentanil used for? Well, it's used in ungulates like rhinoceroses and elephants to tranquilize them. It has no use in humans. And then on the right, you just see some stats about fentanyl. And unfortunately, these are only good through 2015. And the trend has done nothing but gotten worse. But fentanyl is 50 to 100 times more potent than morphine. And carfentanil is 100 times more potent than fentanyl. Fentanyl deaths between 2014 and 2015 rose 73%. And if you go back to 2012 to 2015, there was a 264% increase in fentanyl deaths. This next slide shows, again, I apologize, somewhat busy, but this is data that comes from the Tennessee Department of Health website. And I've included the URL, the link, in blue. Josh, can you see my pointer, by the way, when I point? Oh, well. So if you want to see this graph, and there's a lot of statistics looking at opioid prescribing patterns, overdose rates based on the substance in question. It looks at the numbers across age, gender, race, county, and it spans a 5-year period. One thing I think you've already been made aware of in the course of this summit is that what is starting to outpace the narcotics are the stimulants. So you see over here on the left, the third graph in blue with the blue background, that green line represents deaths from stimulants. Anyway, please go visit this website, www.tn.gov/health, and you will find this and a lot more information, data that I think you'll find very interesting. Moving on to the Drug Addiction Treatment Act of 2000, more commonly called Data 2000. The purpose of this was let me back up. Prior to Data 2000, there was only one FDA-approved medically assisted treatment for opioid use disorder, and that was methadone. And as all of you are aware, methadone can only be obtained in what is called an opioid treatment program, or OTP. They are licensed by the federal government, and sometimes states license them as well. And they're very highly regulated. So not everyone wanted to seek methadone treatment for their substance use disorder. And this molecule was found that had some properties that were like an opiate and properties unlike traditional opiates, that it was realized could be used as an agent to help people get off opioids and avoid the risk of overdose. The intent of Data 2000 was to create the opportunity for this medication called buprenorphine to become more widely available. Now, the federal government had a lot of concern because they didn't want to open the door. On the one hand, they want this agent to be available to treat people who need treatment. On the other hand, they had to counterbalance this with avoiding a situation where they're putting more of a substance on the street that could result in people's death or harm. And so they created this process a provider has to undergo. It's actually very straightforward and simple. There's an 8-hour training course on office-based opioid treatment, or OBOT. After that 8 hours of training, a physician was then able to apply to the DEA to get what's called a waiver, an ex-waivered license. So I didn't mention this in the beginning, but in addition to working at United Healthcare, I also have a private practice. I do many things in that private practice, but one of them is to treat opioid use disorder using Suboxone products. And I've been doing this for a very long time. And so I have 2 DEA numbers, as does everyone who's waivered. The first one is the initial DEA that you're granted. The second DEA begins with X, and that's how they become referred to as X-waivered providers. After the opportunity to prescribe buprenorphine had been available for a while, people started to look at how extensively it was being utilized or not by providers. I forgot to mention that one of the hopes in creating Data 2000 and making buprenorphine available is that providers would be able to prescribe this out of their office. So if you had hundreds of thousands of PCPs and other physicians being waivered in the course of seeing their patients, they, if the patient indicated to them they were having problems with opiates, or maybe the provider was already aware of that, they would be able to talk to the patient about starting buprenorphine. And as a result of that, it would increase access to this medication, and it would reduce the stigma associated with getting treatment. But as I was about to say earlier, when we looked after a while, a couple of years, this had been on the market, when we looked back, there were a large number of people that had these X waivers that had never used them, the vast majority. And those that were using it were only seeing about 3 to 5 patients. So it really was not working as well as the federal government had intended. In 2016, we still continued to encounter the opioid epidemic. It was unabated. So the federal government attempted to increase access by, number one, they created the medication-assisted treatment for opioid use disorder. I don't know if it was an act, but it was a piece of legislation. What it did was it allowed providers to increase the number of patients that they could see. When you first got your DEA waiver, you were limited to 30 patients. After a year, you could apply to the DEA to have that number increased to 100. What this piece of legislation did was enable providers to see up to 250 after the second year. So the hope was they would expand access to this medication treatment. In addition, later in 2016, out came the Comprehensive Addiction Recovery Act, or CARA. CARA was created to open the door for nurse practitioners and PAs to also offer this medication. Instead of 8 hours of training, they were required to take 20 hours of training. And in many cases, they were expected to be supervised by a waivered physician. In the state of Tennessee, for reasons that I can't explain, the door remained closed. It was kept closed. So these providers were not able, even though the federal government allowed, the state of Tennessee did not allow them to prescribe buprenorphine. That is changing. I'm going to talk about that towards the end of the presentation. Then in 2018, along came the SUPPORT Act, Substance Use Disorder Prevention, Opioid Recovery and Treatment for Patients in Communities. I don't know how they come up with some of these names. Anyway, what that did was it opened the door for clinical nurse specialists and certified registered nurse anesthetists, as well as certified nurse midwives, to also begin prescribing buprenorphine after they completed the requisite training. Now, back to OBOT, or office-based opioid treatment. What's the difference between that and opioid treatment programs? Well, as I mentioned before, OTPs are methadone clinics. And they're very highly regulated. Everything they do, from the number of counseling sessions to dosing to documentation, everything is prescribed. And they were only allowed to use methadone. Now that has changed with the advent of CARA. They were also allowed to begin prescribing buprenorphine products. So they're no longer a one pony show. They can prescribe both. OTPs, they have slightly higher success rates because their retention rates are higher. And that's a reflection of the high degree of structure and monitoring that one undergoes when they're in a methadone clinic. And it's not because methadone works better. In fact, I would make the claim that methadone does not work better. It has more side effects, and you have to be very careful about how you're making adjustments to it because of its very long half-life. Office-based opioid treatment is as I said, the administration of buprenorphine in a private practitioner's office. And in the state of Tennessee, we are required to be licensed by the state as non-residential providers of office-based opioid treatment. On the left, you will see the cover page for the manual that was created for this process. It actually is a relatively good manual, and I recommend that you go to the website to the lower right-hand corner where you can download a copy and look through it. What I like about it is it talks about a lot of different things, like what's the best way to assess patients or to do an initial assessment, what kind of physical examinations and laboratory studies should you be doing. It talks about how the structure of your program should look. And so it's a very good document. I recommend it. We're going to spend some time now talking about buprenorphine. But before I jump into that, let me say there are currently 3 FDA-approved medications for the treatment of opiate use disorder. You already know methadone is one of them. You already know buprenorphine is one, the second. And the third is naltrexone. There is an oral form, it's called Revia or Revia, and there is an injectable form called Vivitrol. The injectable form, it's actually a large amount of a highly viscous substance that requires a special injection technique into your gluteus maximus. It's painful. But the good news is it lasts for 30 days. Naltrexone, when you look at comparative studies between methadone, buprenorphine, and naltrexone, it does just as good of a job reducing cravings and withdrawal. Well, withdrawal isn't an issue, I'll explain. But it works as well to reduce cravings as the other two agents. Withdrawal isn't an issue because naltrexone is an opiate receptor antagonist. That means it binds to the primary opioid receptor called the mu receptor, and it binds with high affinity. It will, if you have opiates on those receptors, it will dislodge them immediately. And if you have a lot of opiate receptors that are occupied by opiates and they're dislodged, that's called precipitated withdrawal. We want to avoid that. The way to do that is you don't administer naltrexone until the person has been free of any opiate for 7 to 10 days. This has importance when you're a facility that medically withdraws people from opiates, because you can't really start this medication for 7 to 10 days. So what do you do with the patient? Because insurance companies traditionally will not pay for a patient basically to be waiting on a very expensive unit for 7 to 10 days. So what typically they are willing to do is to allow these patients to go into IOP programs with boarding. And they can have more structure and supervision while they wait it out. And they get the naltrexone. Now let's go back to buprenorphine. Buprenorphine is a very interesting agent. It is a partial opioid receptor agonist working at the mu opioid receptor. There's about 4 different types of opiate receptors, and the action is at the mu receptor. It, like naltrexone, has very high affinity for the receptor. So if you have opiates in your system and you are given buprenorphine, you will go into withdrawal, precipitated withdrawal. What do you do if you're a practitioner and you unknowingly, unwittingly have given someone a medication and they've caused them to go into withdrawal? Well, actually, the way out of it is you have to increase the dose of buprenorphine until the quantities in the bloodstream and ultimately the cerebral spinal fluid are high enough to occupy the receptors that had the opiate displaced from them. And then it has, again, high affinity. So when an individual who's taken buprenorphine takes an opiate, that the buprenorphine prevents them from having a euphoric reaction, because it will not be displaced and the opiate can't lodge and activate the receptor. Buprenorphine itself activates the receptor as a partial agonist, but it's not full activation, and that turns out to be adventitious for different reasons. So some of you might be thinking, well, Dr. Fried, you're saying if you're on buprenorphine that you can't take opioids. Well, what happens if someone's in a car wreck and they need opiates for pain management? Well, there is an opiate called sufentanil that is used in EDs, and it actually is one opiate with higher mu receptor affinity than buprenorphine. So it will displace buprenorphine, it will fully activate the receptor and give analgesia. Buprenorphine also has analgesic properties. I'm going to talk about that momentarily. The half-life. Do all of you know what half-life refers to? It refers to when you take a medication of any type, there's a certain amount of time, and each chemical has a different time that it takes to get from your stomach into your bloodstream and then to the site where it's active, your brain, kidneys, lungs, whatever the case may be. So when you take the substance orally, how long does it take to get the maximum dose? So you take that point in time, and then how long from that maximum dose in your bloodstream does it take to get to half of that dose? And that is the half-life. Hopefully I explained that adequately so you can understand what I'm talking about. But the point I want to make is half-life is how long a substance lasts in your system. And for buprenorphine, it's quite long. It prevents withdrawal for 36 to 72 hours. 16 milligrams is the usual starting dose. And there's a reason for that. It's because that is the dose at which you have 95% of your mu opiate receptors blocked. And that other 5% really doesn't make a lot of difference. So the maximum dose of this medication is 32 milligrams. But I have never started a patient on more than 16 milligrams because it's just not necessary to do. The fact that it gets to 95% at 16 milligrams and really has no additional benefit, with some exceptions. There's always an exception. But for the most part, it really doesn't add any value. And for that reason, it's identified 16 milligrams as the ceiling level, and it creates what's called the ceiling effect. The ceiling effect is responsible for the fact that buprenorphine, people are not likely to die of respiratory failure because of that. So you're much less likely to die. And I think I may refer to this later. If not, I'll bring it up. But, oh, here it is. As I said, because it's a partial agonist, it does not cause tolerance, and many side effects that are associated with opioids are not seen. And that would include constipation and sedation or nodding out. Buprenorphine is not very euphorogenic. There's a lot of concern about diversion of Suboxone and Subutex. And I don't think it's really warranted. When I talk to my patients, again, there's exceptions to what I'm about to say, but as a general rule of thumb, patients don't use buprenorphine to get high. If you talk to people in law enforcement and people who don't treat patients and talk to them, they will tell you that people are out there using this to get high. And I really don't think that's accurate. When I ask my patients, they laugh at me and they say, are you kidding? You don't get euphoria on this. Now, some people will get a mild buzz when they first start taking this orally. But that goes away very quickly. So I'm saying people don't take it to get high, but it is sold on the black market. Why is that? Well, people don't take it to get high, they take it to get by. People take this medication because they want to get off heroin. People take this medication because they couldn't connect with their supplier of opioids. So they use it to get by. And one of the benefits of the fact this is diverted is that individuals are able to experience this, or friends will give this to them, or however they obtain it illicitly. They realize immediately how it makes them feel very different, and they're encouraged to seek treatment. In this day and era, I don't have new patients that haven't had a buprenorphine product that they've gotten off the street, or they come from another provider who is prescribing it for them. And I believe because of that, they've come into treatment, and as a result, they're not at risk of overdose death. According to Tennessee Department of Health data, in 2016, there were 1,631 overdose deaths. When they took a look at what substance was in an individual's bloodstream, they could break it out according to different substances. Of that 1,631 deaths, 61 had buprenorphine in their system. But of that 61, 45 had other substances that were more likely the cause of death: benzodiazepines and fentanyl. So when you take the remaining 21 and divide it by 1,631, only 1.5% of overdose deaths were due to buprenorphine. Now, you all are aware that there's two forms of well, I'm going to tell you. There are two forms of buprenorphine. One, the hydrochloride, the monotherapy, the formulation without naloxone. And then most of the other formulations have naloxone. Naloxone is not absorbed in the mouth or the gut. So one might ask, what's the purpose of adding naloxone? The purpose is, well, before I say that, naloxone is active when you inject it. So the purpose of the naloxone is to prevent people from injecting this medication to try and get high. And because of that, Subutex, the monotherapy, will have a higher cost on the black market than Suboxone products or any other product that contains naloxone. Buprenorphine is also an analgesic. It's quite good at that. So individuals who got hooked on opiates because of pain conditions, they sometimes have reluctance to go to buprenorphine because they have concerns that their pain won't be adequately managed. What I think a lot of providers may not know this, but to the benefits that someone gets in terms of preventing withdrawal last 36 to 72 hours. The analgesic effects, on the other hand, only last about 4 to 6 hours. So a person needs, if they don't have pain, there's no need for them to take this medication more than once a day. And in fact, I tell my patients, you should take this only once a day. And the reason is because you trained your brain to take an opiate every 4 to 6 hours. And this is a way to kind of move your brain and retrain it. So the exception to that is when they have pain, I tell them you need to divide your dose and take it 3 or 4 times a day for that reason. Buprenorphine is only absorbed in the mouth, not in the stomach or intestinal tract. I mentioned it can be prescribed as a monotherapy or with naloxone. I told you what naloxone was. It's a cousin, by the way. Well, naloxone is Narcan. One thing I wanted to mention, because I don't know if this was stated earlier, but naloxone certainly revives someone from an opiate overdose, but you have to call 911 because that individual, the naloxone wears off and the individual can still have a lot of opiate in their system and succumb again to overdose. So you may need, the point I'm making, you may need multiple doses of Narcan, and it's best if that is administered in an emergency room. Okay. Now we'll move on to take a look at the different types of products, buprenorphine products. Everything started with Suboxone, buprenorphine naloxone film strips. And when Suboxone first came out, it was in a tablet form. And then the company came out with this product in a film strip. And the nice thing about the film strip from a MAT provider management perspective, is they came in these foil packages. And each of the foil packages were numbered, and they were numbered sequentially. So when the individual picks it up at the pharmacy, they'll get, say, 30, and they'll all be sequentially numbered. So you can have them bring their foils, they're called, bring their foils in to an appointment, and you can do a count. And you can see that they're sequential in number. So you have a pretty good idea that that individual is not diverting. But they've subsequently have come out, and the other thing about the Suboxone, it was very expensive. And I was quite disappointed by that. And a lot of pharmaceutical agents, because they charge far more than it costs them to make it. And their justification is that they're just recouping the cost of getting it to market. And the investigations and research they have to do to identify it and then get it to market. They say that costs millions and millions of dollars. I don't doubt that, but they make billions and billions of dollars selling these products. So it just doesn't seem right to me, and I know many of you agree with that. So there is now a generic tablet and film strip. There is the tablet form of buprenorphine without naloxone called Subutex. Subutex was the same company, Rickett Benckiser, and that company is still well known for a product that it sells. It will surprise you when I tell you it's Lysol, but they no longer manufacture and distribute this product. They sold it to another company. But when they came out with Suboxone, they came out with the monotherapy and called it Subutex. Well, Subutex doesn't actually exist. It's like the name Kleenex. Anything that's a tissue we refer to as Kleenex, even if it's not Kleenex brand. That's what happened to Subutex. And then there are sublingual tablets marketed under the name of Zubsolv. They come in slightly different doses because the absorption of Zubsolv is a little bit better, so you need a little less. Then there is Bunavail. That's a buccal film. That just means that you take off the back of this clear plastic-like strip and you adhere it to the inside of your mouth. And because it's directly attached to your skin, its absorption is greater. So its dose of buprenorphine is even lower than Zubsolv. Then there's a form, an implantable form called probufene. This is not used very often. And one of the reasons is well, it lasts for 6 months. That's great. And from a management perspective, it's implanted in the forearm. And because of that, you don't have to worry about diversion and things like that. But you have to, it's a minor surgical procedure to implant them. And then these little rods there's 4 of them, 42 nanometers or millimeters rather. And they can break in your arm and they can migrate. So removing them can become somewhat of a challenge. Removing also done under a sterile process. And finally, there is a medication, an injectable form of buprenorphine called Sublocade. And you tent the skin of your belly, just like sometimes people administer insulin in this fashion. Tent the skin of the belly, you put a small needle where it's tented, inject the substance, and you're done. It's relatively painless, lasts 30 days. And people that I hear that take it, most of them really like it. You don't have to go to a pharmacy, you get it in your doctor's office. And for those of you who may not know this, one of the most stigmatizing places, according to my patients, is at the pharmacy. A lot of pharmacists are very good, and they treat people like you would like to be treated in this type of circumstances. But sometimes pharmacists are not that way at all, and they create a lot of torment and grief for individuals picking up their prescriptions. Now, something I don't think you have heard about is there are 2 other forms of buprenorphine. They're FDA approved for mild to moderate pain, and they are not supposed to be used for opiate withdrawal. And that would be the Butrans patch and Belbuca, which is an oral tablet you put under your tongue, just like you do Subutex.
Hey, Dr. Freed.
Yes.
We're running short on time. We do have a couple of questions. Is there anything that you wanted to really cover that you haven't been able to cover yet before we go to questions?
I just want to say that TennCare has this program, and hopefully you'll have this deck so you can look through this, and there are links to the website where you can obtain even additional information. What TennCare is attempting to do is create a network of high quality buprenorphine or buprenorphine providers, so that there's capacity to treat any person that is seeking treatment and has TennCare insurance. And
we will make sure the slide deck is available.
Thank you, Josh. Appreciate that. Now, outside of that, I really didn't have anything else.
Well, it was a great presentation. I learned a lot, and I thought I knew a lot, but I learned a lot. So I have a question from Bernetta Delk. It says, when a patient is on buprenorphine, does the patient have to wear medical badges so that first responders can recognize that the individual is on the drug to avoid negative drug interaction, or that they are fighting an addiction?
It's they don't have to, but it's recommended that they carry a card, or they have some type of wrist or neck based notification to an EMS provider. So not required, but advised. Not a lot of people do so, but.
Casey is asking, do you believe Tennessee will ever allow buprenorphine products for use with chronic pain management, or do they already?
No. unless, well, let me tell you, if the member has comorbid pain with their substance use disorder, specifically opiate use disorder, then yes, you can treat the pain, but you're actually not treating the pain, you're treating opiate use disorder. But one of the benefits, as I mentioned, is buprenorphine has analgesic properties. Now, if the pain is greater than moderate in intensity, it's probably not going to work very well. And methadone might be a better option in that case. But remember, I also pointed out there are 2 medications you don't have to be ex-waivered to prescribe, and that's Butrans and Belbuca.
Duranda has a great question. I've been wondering about this myself. So kratom, does it have potential to combat opioid addiction? Do you know if kratom actually staves off withdrawals?
Well, yeah, it does. And I've heard this from patients and other sources that the tea or other formulations actually can be helpful in withdrawal for them. What my impression, however, is that most of the time it really doesn't work out very well for the individual. And let me explain why. They get off the opiate, but they haven't addressed the underlying reasons that they migrated to use of substances in the first place. And for most individuals with substance use disorder, they have in their childhood before age 18, 4 or more adverse childhood experiences. So a lot of people are substance use disordered because of trauma they've experienced in the past. But you have to remember, when a person spends all of their waking hours, they wake up thinking about, I'm in withdrawal, I need to get a hold of something. Do I have the money? Where can I get the money? Who can I call to go out and get it? And then they get it and they use it. Then they're high. Then they spend another segment of the day coming off of it and feeling miserable. And they go back to sleep or pass out and start all over again. So you can't, very often anyway, successfully keep someone off an opiate unless you've addressed those other issues and you've helped them establish a life.
Right.
All right.
I just want to let everybody know, I have put the link to the evaluation in the chat box, so you guys can get your credit for this presentation. And just real quick, Dr. Freed, I wanted to ask you, so I saw a doctor from New York speak, and as a whole in the medical community, is buprenorphine and methadone becoming more accepted as a long-term medication as opposed to let's do this for a short period of time and then get to total abstinence?
Yes, yes, the answer is yes. Okay. More and more people are becoming aware this isn't a matter or issue of willpower, that this is a brain disease. And I think that what I tell people, and my patients in particular, I recommend you be on this for a year. And I base that on the fact NIDA has done studies looking at brain scans, and it takes a year for the brain to, especially the reward circuitry, to repair itself.
Right.
And also it takes time for the individual to build a life that can replace the compulsive pursuit of opiates.
Yeah, so it's another form of harm reduction, really.
It is, yes.
All right, well, thank you so much for being with us. We'll get in contact with you to get your PowerPoint presentation if we don't already have it. And if we do, we will make it available. And thank you so much for your time. We really appreciate it.
You're very welcome. And I want to thank you and everyone else for inviting me. I've enjoyed this. Thank you so much. Have a good weekend, everyone.